Hello again and welcome to the first lecture of this third week of the Psychiatry and Overview course. In the last 2 weeks, we have tried to cover and give you an overview of how the brain functions, how the brain neurons network and how do they create a mind. And in the second week, we tried to introduce to you the whole concept of normalcy and abnormalcy, on what basis the mental illnesses are diagnosed, on what basis we classify them, and in some cases where we suspect that there is underlying comorbid illness or some other cause for behavioral disorder, we try to investigate. So, this week what I will try to attempt is try to introduce you to some major illnesses in psychiatry, something which are very commonplace words which all of you know, and some of them are used in common language and referring to people's behavior. But when we analyze behavior and when we use common words, they may not always mean to be a mental illness. So, I will try and introduce to you about these concepts and how they are diagnosed. It will be useful for the doctors amongst you and to also to psychologists who will work with doctor in clinical psychology and other areas, and to neuroscientists, because obviously as I said in the beginning, studying abnormality may be a window to understanding brain through behavioral observation and through tools like imaging. So, let us get on to it. So, today the first thing I would like to introduce to you what we call organic mental disorder. When I say organic, it means arising out of the brain. It does not mean that where we cannot discern a cause, that is not organic. What used to be called previously is a functional disorder. So, either it is a disorder of structure or function, but either way the function can get disturbed. So, all behavioral problems and all normal behavior is organic in that sense. But when we talk in the classificatory system, we look at a group of behavioral disturbances which are called like mental disorders with cognitive disturbances and possible etiology, where we suspect that there may be a cause of the behavioral disturbance. But the prominent thing is cognitive disturbance. Cognition, as you know, involves thinking and your will, your cognition, the perception, largely the areas which are covered by what we call being conscious, not in the sense of being oriented to time, place, person, that is also part of. So, orientation, thinking, perception, abstraction, all that is part of cognition. We suspect that there may be a etiology in it, and hence we call it organic. Now, this is one of the commonest thing which we all know, but this is like a classification, we can just run through it. It is like a dementia in Alzheimer's disease, vascular dementia, dementia. So, you can see few words, you can see dementia, you can see amnesia, we can see delirium, other mental disorder due to brain damage and dysfunction, personality and behavioral disorders due to brain disease, and unspecified. So, broadly, you know, we are talking about something called dementia, something about amnesia which is related to memory, delirium is another word, and other mental disorder. As we go along, I will explain it to you. You must have heard a lot of these words in your. So, dementia, when we talk about somebody having dementia, in not a pejorative term that this person is demented, which is a part of language, but dementia is a syndrome, which is a collection of symptoms characterized by progressive decline in memory, intellect and personality. So, normally people start feeling that there is a problem when the attendants or people around the person start noticing some recent memory deficits. Now, one has to differentiate between ordinary forgetfulness which all of us can have at times, when our mind is too preoccupied with something or in a state of heightened emotionality, we may all suffer a little bit of forgetfulness. As the age increases, people become forgetful. We all know when we see the older generation, the older people around us, they tend to complain that we keep something and we forget or forget the name. Now, all that is not dementia. That probably is a benign forgetfulness associated with old age. Dementia has to have progressive decline, but the first to appear in normally in the dementia of Alzheimer's type, which is the commonest, is the recent memory deficit. If you remember the lecture which I gave you on the functioning and the psychology of the way brain works, we talked about immediate memory, which is actually immediate. I tell you something and you recall it back and tell me. A short term memory, where the information which goes in is consolidated, and the long term memory. So, the first symptom which actually appear is recent memory. There is a deficit in cognitive function, in thinking, judgment, planning. There is no alteration in the consciousness. The person may be very, very oriented to time, place, person, unless they really progress to a very significant deficits later on. The secondary mood disturbance or psychotic symptoms. We talked about psychotic symptoms previously. You would remember it, not being in touch with reality, having hallucinations or delusion. There is a change in behavior, which corresponds to the change in personality, and the symptoms are evident for at least 6 months. Now, this is very, very indicative, because what we have found out in pathology and the histopathology and the imaging and in the dementia patient is the area where we find the maximum damage is the hippocampus, which is deep tucked in the temporal lobe, if you remember. Now, this recent memory is the disruption of the network in that area, and that is why it is the earliest to appear. But as it progresses, the whole brain is like shrinking. You remember I told you that our brain starts shrinking after initial growth by 16 or 18 years of age, and it goes on shrinking, but not all of us land up in dementia. So, dementia still is a point, a trigger where brain starts shrinking much faster than it happens in a benign aging process. And later on, these cognitive functions like thinking, judgment, which are more or less controlled, or they are integrated by other areas of the brain, those areas also start getting damaged. So, it is an insidious onset or acute onset. So, how do you differentiate whether you see the dementia has gone in slowly or it has suddenly come up? This is important to know when you are judging a person as a clinician or as a psychologist, because that normally will give you an idea whether you have to investigate further, because it could be a irreversible process like in dementia of Alzheimer's type, or it could be a reversible process having some other causes to this decline in memory and intellect. So, as I said, Alzheimer's is the commonest. It is a primary degenerative disease. Primary means that normally there is no other cause which leads to this. There are other dementias which can happen because of the cause. We still do not know the cause in spite of all the research, but what we know with the study of postmortem and other imaging, that the number of neurons undergoes a marked reduction, and all these areas where the neurons are reduced in quantity, what we find is neurofibrillary tangles. There is the appearance of neurofibrillary tangles and senile plaques. This is almost a confirmed finding in dementia of Alzheimer's type. Now, the other problem is, but we cannot take out a brain tissue and study unless we are doing research and we get permission to study all this. So, normally Alzheimer's type dementia remains a postmortem diagnosis. With imaging and spectroscopy, nuclear magnetic spectroscopy, we are able to see the changes in amyloid and this type of thing, but still largely it has not come to really clinical practice. The major disturbance in the neurotransmitter is the system of acetylcholine. Now, this cholinergic system is implicated in normal memory. It is also especially the what you call a nucleus basalis of Menard and the cholinergic system in the forebrain, they are implicated in the memory, and so the major damage to the neurons is those which manage the acetylcholine levels. So, we have to see whether there is a dementia before the age of 65 or it is after 65. If you look at the family history of Alzheimer's disease or Down syndrome, Down syndrome is one of the genetic syndrome, normally what you call mongoloid kids. This is because of a chromosomal aberration. A history of Down syndrome, or in people who have Down syndrome, their risk of having Alzheimer's is much more. But in the people who have onset of dementia before 65, there is a very rapid deterioration. And these are like the symptom like aphasia, agraphia, difficulty in writing, difficulty in reading, difficulty in coordinating complex movements like wearing a shirt or closing an envelope. These coordinated activities, they get disrupted in the people who have a onset before 65, whereas people who have a onset of illness after 65, it is a very slow progression. Now, but as they progress, they get into a severe impairment of memory. They can confabulate, they can, to cover up their story, the mind creates, to cover up the loss of memory, the mind creates stories. There is something called pseudo dementia, which in modern parlance we will call it dementia with depression. One sign of it is, which is a robust sign, that people who have depression and are having cognitive deficits because of depression and other illnesses, they themselves complain of difficulty in remembering. Whereas the person who is slowly progressing towards dementia is slightly aware of this deficits and tries to cover up till it gets out of hand for him or her. They try to cover up, they have no insight into it in that sense. So, there is no drug treatment which is very specific for Alzheimer's disease, but these are the type of drugs which are used. They all actually act on either enzymes which break down acetylcholine. So, if you prevent the breakdown of acetylcholine through this enzyme called cholinesterase, if you can see it here, in that case the acetylcholine levels will be high. So, the memory problems may slightly decrease, or you give something to increase the acetylcholine itself, or you give something to stimulate those receptors on which acetylcholine acts, because as you remember all neurotransmitters are secreted and they act on the receptors into the postsynaptic neuron. So, cholinesterase inhibitors with augmentation with drugs like selegiline, nootropic agents are non-specific thing, vitamins, metabolic enhancers, there are a lot of drugs which are being tried, nerve growth factors, things like aspirin, lot of these drugs are being tried, but in fact, if you look at it, only very few of them like donepezil to some extent, and these are the only drugs which to some extent can help it, but they are still not the treatment. They may maintain a status quo for some time till is another phase. So, but what can be done? All these dementia patients may have lot of other symptoms like mood symptoms, like psychotic symptoms. They can be treated with these specific. We talk about these drugs as we talk about other illnesses, like for depression and anxiety, the psychosis, the sleep problem, all this can be treated. But the mainstay, if you look at it, and here is where clinical psychologists and rehabilitation psychologists, they come in picture. Because there is no drug treatment, so in fact, as the worsening goes on, it is the environment which has to adapt to the patient and really help him in adjusting, rather than straining the patient and expecting him or forcing him to adapt to the environment. So, one has to really keep re-educating people, attendant and the patient of the cognitive and emotional changes. Family education and therapy is very important, like there is something called Alzheimer's Society, which people can, once diagnosed, people can join and keep discussing like self-help groups, There are small things which have to be kept in mind while you are talking about this re-education, is that instead of forcing the patient to asking him questions, one can supplement with information. One can make a colored mark on the way of the daily chores, like going to the bathroom can be marked by a color, a calendar can be put, or now with all the digital technology, alarms can be used to keep reminding. All these things go on making the remaining neurons active and reorienting some amount of neuroplasticity. The brain, when it is shrinking, also tries to, because of Alzheimer's when it is doing it, it also tries to recompensate. So, retraining, retraining and retraining, that is the process, while taking care of rest of the behavioral symptoms with medication. So, the other dementia is like a vascular dementia, where commonest is a multi-infarct. Now, vascular means that there are signs of dementia, of memory, personality, intellect, but all this impairment is uneven. It is not slow progressing in a linear curve like Alzheimer's, because this dementia appears because of the damage to brain tissue by obstructing blood supply, or there is a hemorrhage in that area. Now, this can range from very large areas to small pinhead size infarcts in deeper areas called basal ganglia. So, every time this happens, there may be a worsening of a cognitive symptom. It is like there is a huge network of brain which we talk about. There is a small node where this blood supply is stopped, the brain tissue is damaged and the circuit is broken. The larger the size of the infarct, the greater the damage too. So, that leads to uneven impairment, because infarcts may be spread into a wide area and may not be a really progressive connected thing. This is dependent on the neurological signs, because suppose if there is a bleed or an infarct in a left cortical area where the speech area is there. So, there may be a speech deficiency, but there may also be a paralysis of the right side of the body, which is controlled by the left. Insight and judgment are relatively well preserved unless those areas of cortical connections are really damaged. This can have an abrupt onset. As the blood supply is damaged, there will be a abrupt onset and a stepwise deterioration. You can also, the doctor should notice there could be hypertension, which has to be treated depending on which area of the brain is damaged. Like in the frontal lobe, if you remember the structure of the brain, this convex curvature which you see and the deeper structure, depending on which area is damaged, you will see the syndrome of behavior according to that. You can see emotional lability, people will keep suddenly switch into different moods briefly and then come back to normalcy. The episodes of clouded consciousness may happen along with whenever there is a bleed, or personality is largely well preserved, but normally in a vascular dementia it is the change of personality which comes first, and memory, the loss of memory, recent memory deficit as seen in Alzheimer's is not so prominent, unless the infarct or the cerebrovascular accident has actually happened in the area of hippocampus or where the Papage circuit where memories are formed. But damage to frontal lobes, the areas which are the central executive networks, all this accentuation of previous traits can happen, egocentrism, paranoid, irritability. Right. So, this you can say after section of strokes or single large infarction, more gradual in onset after a number of minor ischemic episode, destruction in the deep white matter. These are just the classificatory system depending on how the deterioration has happened. Now, dementia can also happen with other diseases. This can happen at any time of life, and the presence of features can be like a vascular dementia or progressive like Alzheimer's. Pick's disease, another type of dementia where you see the memory disturbances much later stage. What suddenly happens is it is a progressive thing like Alzheimer's, but normally it is the frontal lobe, as I said. The mood changes or the emotion may be blunt, behavior may suddenly change, there could be a disinhibition or total loss of interest in the surroundings. Now, if you are seeing a sudden change in a person who has not had history of any other illness, say in a age group of 40, 55, anything beyond 45 to 65, a sudden behavioral change which is not transitory, it is worsening. Person may be suddenly becoming very explosive or suddenly getting very angry, moody, and he does not have a history of bipolar illness or any other psychiatric illness. One should suspect in whatever, even as a lay person and a non-doctor person can also suspect that there could be something going wrong. It may not necessarily be Pick's disease, but one should visit the doctor and get at least a CT scan or a MRI done to know what is happening to the frontal lobe. There is another type of dementia which is rare, but it is called Creutzfeldt-Jakob disease. It is a very rapidly progressing from months to 1 to 2 years. Alzheimer's, if you remember, is a very, very slow disease. If it is happening and it slowly grows, if you are finding there is an acute onset of dementia syndrome, one should suspect it could be a vascular thing and visit the doctor to get a imaging done, MRI and all that, or a change in behavior. But you do not suspect dementia in people of 16 or 18. So, you are talking of dementia in pretty old age. Roughly arbitrarily you can say before 65 or after 65. So, roughly between 55 to 65 in a person who is not having any problem, he starts losing memory or starts behaving abnormally in the sense of abnormal behavior or explosive behavior or disinhibition, or on the vice versa withdrawn apathy. It could be depression or it could be mania, but still you should suspect and get investigated. Creutzfeldt-Jakob disease is fairly rapidly progressing over months to 1 or 2 years, and you can find multiple neurological signs, difficulty in movement or difficulty in holding things or tremors or sudden movement or jerky movements. When you ask the person to walk straight like in ataxia, the person may not be able to hold on. Creutzfeldt-Jakob disease, the clinching evidence is EEG. You find triphasic slow waves, and this is one of the places where EEG is very useful, and the other places which is useful is encephalopathy and other things, which I will just briefly mention as I move on. Huntington's disease, which are neurological genetic disease. In Parkinson's disease, you all would have heard it, but there are no definitely distinguishing features. HIV is associated with dementia when it affects the brain, and we see more and more patients of this. GPI was a sequelae of syphilis, which is become rare now. The other the organic syndrome which is important is delirium. Delirium which is not induced by alcohol and other substances. So, here it is an impairment of consciousness and attention. In a withdrawal phase of alcohol it happens, but otherwise delirium can happen because of alcohol withdrawal, but without it also. There is a disturbance of cognition, perceptual distortions like hallucinations, impairment of abstract thinking, psychomotor, either person will be agitated or dull, disturbance of sleep, emotional disturbance. Now, this is a transitory thing. Delirium is not as progressive and continuous as dementia is. It is a transitory impairment of consciousness and attention. The person may be looking perplexed, dazed, picking up objects in the air, which is visual hallucination, will not be able to think clearly, will not be able to make clear judgment, and is actually a risk to himself or to somebody else. So, delirium is an emergency which has to be treated. It is organic, but a person whom you feel is suddenly was all right, and because of whatever reason which can be investigated, it can happen in alcohol withdrawal also. The person is totally lost, dazed, and as I said, you can find out the perplexity is the core sign, confusion and perplexity. The other thing is which you should look at, these are things which can be investigated once you take to the doctor, but suspect when you find such symptom a temporal relationship between the development of the disease and the onset of mental syndrome, and recovery from the mental disorders when you remove the cause. So, these are type of things which like organic hallucinosis, organic catatonia, delusions. These syndromes like affective disorder, hallucinosis, depression, anxiety can happen in their own right, and they are diagnosed as such, but they can also happen when there is a cause for it, underlying cause, like what we call organic hallucinosis or organic mood disorder. Because in their own right, when we diagnose depression or mania, normally we do not find any cause. So, there can be a personality change due to brain disease, and this is more progressive, as I said, a part of which you find in Pick's disease or vascular dementia. Brain infections can cause, injury can cause, like post concussional syndrome. Symptomatic dementia, as I said, can happen because of other illnesses like with alcohol, Korsakoff, Wernicke, lack of vitamin, intoxicant like solvents. Lot of people abuse solvents, vitamin deficit, B12 is very common. Vitamin B12 deficiency is one of the commonest cause of leading to dementia. Hypothyroid can lead to this. Metabolic dementia, hyponatremia with kidney diseases, what is called uremic, with Wilson's disease, which is liver encephalopathy, hypoxia, trauma, epilepsy, all these things which are affecting brain either directly or as a sequelae can lead to dementia. Now, just to sum it up, when, as I said in the beginning, brain is electrical and chemical activity is going on continuously, and it is the network of the brain which fires and creates the frame of reality depending on the external stimuli in the context in which we are living, and it keeps learning, memorizing not only your personal, emotional, declarative, episodic memory, but also the reflex, the motor movement, basically to sustain you. Now, psychiatric illnesses, like we will be discussing further in few lectures, we have not been able to really delineate a definite cause to them, whether genetic or the problem in the anatomy or physiology, but in some cases, in a very small percentage, the behavioral abnormalities may be due to underlying causes. As I said, symptomatic delirium or symptomatic difficulty in memory, personality, with it can happen because of the vascular thing, it can happen because of the tumor in the brain, it can happen because of the intoxication, vitamin B12 deficiency, in the phases of alcohol withdrawal or alcohol intoxication. So, when they happen in association with a definite cause, then we call it organic mood disorder or organic hallucinosis or organic hallucinatory syndrome, what we call now organic personality change. Beyond this, there are set of illnesses, just to recap, like dementia, which is a slowly progressing deterioration in memory, intellect or personality. Alzheimer's is a syndrome in itself, which is progressive, slow, insidious. It can happen in a very rapidly deteriorating fashion. Then you have to suspect things like Creutzfeldt-Jakob, or it can happen in a stepwise deterioration, which is probably happens in vascular dementia. The signs which you will find depends on which area of brain is getting damaged. In Alzheimer's, the whole brain actually gets progressively involved, and in vascular dementia as and when, depending on which area is damaged. So, this was a broad overview, bird's eye view of what organic is. In the next session, we will talk about another major illness called schizophrenia. Thank you.